Good morning, everyone, and good afternoon to others. Before we begin, I will give you some instruction for those who wish to listen to this presentation in Spanish. Antes de empezar, para los participantes que desean escuchar esta presentación en español, encontrarán un icono en su pantalla que dice Interpretación. Si hacen clic en este icono, tendrán la opción de elegir el idioma español. Si no ven este icono, muevan su cursor en la parte inferior de la pantalla y aparecerá una barra de herramientas con el icono. También le recomendamos silenciar el audio original para escuchar mejor la traducción. Muchísimas gracias. Bienvenidas a todas y todos. I will continue in English. My name is Ferdinando Regalia. I'm the Division Chief of the Social Protection and Health Division here at the IDB. And I want to welcome all of you to the 9th conference in our Policy Dialogue series on strategies to respond to COVID-19 pandemic. In the context of this pandemic, we are all being permanently and painfully reminded that we don't have enough tests, respirator, and health workers to meet all our needs. And this scarcity of resources implies that confronting the pandemic involves difficult decisions, an important trade-off at many levels. And I think the same will be true when a potential vaccine or effective treatment will come available. What should guide priority setting when deciding which COVID-19 patient get what quality of care and how to allocate health resources between routine health care and care related to COVID-19 are very important problems. And in today's conference, we will discuss the difficult choices that are being made at the front line and present some guidance on how explicit priority setting and the further incorporation of ethical principles may improve this decision in the future. Our guest speaker will approach this topic from 3 different angles: an international and general perspective, focusing on low and middle income countries, the viewpoint of a clinician at the forefront of the response to COVID-19, and an ethical perspective. Now, allow me to introduce our speakers. Welcome to Amanda Glassman. She's the Executive Vice President of the Center for Global Development and also serves as Chief Executive Officer of CGD European's office. She has accumulated more than 25 years of experience working in health and social protection policy and programs in Latin America and around the world. Prior to joining CGD, she was principal and specialist at this house, at the IDB, and also she was previously Deputy Director of the Global Health Financing Initiative at the Brookings Institutions. Amanda is known by almost everyone in the region, or maybe everyone. She's an internationally recognized authority in global health policy, and her publication on priority setting in health have been widely disseminated around the world. Thanks, Amanda, for joining us. And also want to present our second guest, is Professor Robert Klitzman. Robert is Professor of Psychiatry at the College of Physicians and Surgeons, the Joseph Mailman School of Public Health, and the Academic Director of the Master of Science Bioethics at Columbia University. He co-founded and co-directed the Columbia University Center for Bioethics. He served on the US Department of Defense Research Ethics Advisory Panel. He has published numerous scientific articles, books, and chapters on critical issues in bioethics. Most recently, we have seen his name showing up in different media over the last months, discussing ethical aspects related to the management of the pandemic. And last but not least, welcome to Robert. And last but not least, it's our third panelist, and it's my pleasure to introduce to you Dr. Javier Arcos. He comes from the real front lines of the pandemic. Dr. Arcos is the Deputy Medical Director of Villalba General Hospital in Madrid, Spain, and is the coordinator of the Organizational and Clinical Innovation Unit of the Quironsalud Public Hospital Network in Madrid. He's also a professor of Humanitarian Health and International Cooperation at the Universidad Autónoma de Madrid. Dr. Arcos was also the coordinator of complex humanitarian emergency setting at the NGO Médicos del Mundo. Before we welcome Dr. Arcos. Before we begin our panel, I invite everyone to ask a question through the session by sending them to the Q&A icon of the Zoom platform. Our speaker will respond to our question at the end of the panel, but we will start first with a moderate panel by Bill Savedoff. Bill is a principal health specialist in the division at the IDB, and I'm gonna pass the word to him. Without further ado, we begin the discussion. Thanks very much.
Thank you, Ferdinando. And I want to say I'm very honored to be moderating this panel. It's a really great set of people, and we're dealing with some really tough questions. Before we continue, I want to remind people, as Ferdinando did, about the translation at the bottom. One of our speakers may switch into Spanish, so those of you who speak English have to pay attention as well and exercise your index finger on that little globe icon on the bottom for translation. Amanda, I'd like to start by asking you sort of the broad picture here. CGD's raised a lot of concerns about the tough choices that countries are making during the pandemic, but often without explicitly recognizing the trade-offs. So if you could just start by talking about how do you see, how would you characterize these choices and trade-offs, and why would you say that they matter?
Thank you, Bill, and great to be with all of you again. We're seeing about at least three allocation choices, and within each area of allocation trade-offs, few of which have been clearly articulated by policymakers and their partners and haven't really been examined empirically. So the first choice is how we're going to spend between the health sector and the rest. The IMF is showing that low-income and emerging markets are spending a little bit more on health, but not much more. There's an increase of about 0.2 to 0.3% of GDP. That hardly represents a surge, okay? The social protection and firms' response has been several orders of magnitude larger, and that's fine, given that the effects of the recession on well-being and the relationship between recessions and health is also important and has important effects. But we have to recognize that without driving down the virus, the rest won't work and will just increase the costs associated with those pieces of the response. So I do think we need to rethink the magnitude of resources going into the health sector urgently. And I wonder, are countries even doing the fiscal planning necessary to purchase an eventual vaccine, for example? Second, there's the critical allocation choice and allocation of money, effort between healthcare and prevention, clinical care and prevention. We are seeing countries scale up oxygen, ventilators, but how much money and effort is going to interventions that enable hand washing and distributing, encouraging the use of masks, for example, that might make a larger impact on the spread of the disease? And finally, there's the question, I think, that occupies most of our panel, which is within clinical care, what to do. Here, too, we need to take a whole of health approach. In other words, we need to look at the net impact of measures taken on health outcomes, and excess deaths are a rough way to look at this issue and have been of increasing importance, especially because cause of death data from low middle income countries is very poor and very incomplete. So really we are relying on those totals of deaths to understand what's happening. I would say that at the start of this pandemic, we didn't have enough data on COVID-19, but we've always had lots of data on other health interventions, their health effects, and their costs. So what we need to do is look at, we know that letting vaccination rates fall, not providing reproductive health services, not doing early management of some cancers, for example, the health risk of the interruption of these services may be vastly greater than that of COVID-19 itself. We at CGD have posted a tool that enables some self-calculation of the net impact of COVID-19 restriction policies on other outcomes. And I would say this is a lesson we learned in previous outbreaks, and we already know that it causes huge health effects. Why aren't we acting as if we knew that? And this is a very important policy issue that is not addressed. And finally, I think we need to pay better attention to palliative care. There are stories emerging out of the UK and elsewhere that illustrate the extreme hardship that closed or highly restricted services is creating for people who are terminally ill, or for people who would normally be in hospital care and hospice care. And this is, I think it's for the people themselves, but also their families and caregivers. It's quite traumatic. So just to say, I think those are the many allocation choices ahead with huge trade-offs. Thanks.
Thanks, Amanda. That's a fantastic overview. And you packed it into a small period of time. That's a big lot to think about there. I'd like to turn to Dr. Klitzman. Do you prefer Robert or Bob? Do you? Okay, your microphone is on mute.
Robert's fine.
Bob, okay, good. That's sort of the picture we have of these trade-offs that are happening in this broad allocation question. What I wanted to ask you about, people talk about healthcare in terms of fairness, in terms of equity, human rights, and ethical judgments, they often sound simple in the abstract, but they're really extremely painful in specific circumstances. And from the way Amanda was talking about that, we've got some of those pictures. If you could say a little bit about how you see the role of ethics in public policy, public health policy, and is it possible for public health policymakers to consider ethics more generally and in responding to an emergency like this?
Yes, well, great questions. And also, thank you so much for inviting me to this panel and this discussion. I think these are very important issues, and I'm really pleased organizations looking at them, and hopefully we can all learn from each other going forward. So partly to piggyback on what Amanda has said, they're very difficult trade-offs involved, and it's important to have fair processes in thinking about them to involve stakeholders and also aim to have good outcomes, fair outcomes. In general, in bioethics, and as mentioned, I have been involved with bioethics at Columbia University and elsewhere for a number of years. There are several basic principles that we try to follow. One are the rights of individuals, including human rights. People have a right, many of us believe, to a certain amount of health care, et cetera, rights to make decisions for themselves. There are also principles of beneficence. We try to do as much good as we can, and conversely, we try to avoid risks and harms. And we abide by principles of justice. We don't want to unfairly burden one group and unfairly favor another group, but we are concerned about issues of equity and social justice. So these sound, as you say, very simple, but the problem is that they can often conflict, and particularly in a pandemic when there is a public health emergency or crisis, they can conflict. So for instance, we believe that individuals have rights. On the other hand, if people go out and don't use a mask because they don't want to use a mask and don't wash their hands, they're going to spread the virus, and if they have been infected, they're going to infect other people. So there are times that in the name of public health, we say that we need to restrict certain individual rights because of the greater social benefit that's involved. Similarly with, if we only have so many ventilators or so many intensive care unit beds or so many hospital beds, let's say we have a hospital and we only have 100 beds and 10 ICU beds, and we have 1,000 patients. We need to decide which patients will get the bed. So obviously, as Amanda was suggesting earlier, the best cure is prevention. So if we can prevent an increasing number of patients, and if we can prepare in advance, and as Amanda mentioned also, a problem has been that there have been reports in the past following prior public health emergencies, such as the H1N1 pandemic a few years ago. A number of countries and states, the US, New York State, where I am, other states came up with guidelines saying we need to prepare for such emergencies as we're now facing. And we need to invest in long-term benefits in terms of deciding that we're going to stockpile personal protective equipment, masks, that we're going to invest in education, et cetera. And a major problem has been that we respect benefits ethically, but there are short-term and long-term benefits. And a major problem has been that a lot of policymakers have focused on short-term problems and benefits and not thought about long-term ones. And problem. And again, this is yet another illustration of why ethics are crucial in public health and in policy responses to an epidemic, because they involve tensions between we could focus on treating everyone now, or we can spend some of our resources to trying to prevent a future pandemic. And of course, COVID is a problem because it's new. And so we, as Amanda was saying, don't have as much information as we need, but also we know that the curves look like this. It starts out with a few cases and slowly mounts and then hits a tipping point and suddenly takes off. And it's easy when the numbers are still low to think, okay, well, they'll just go away. We policymakers can be in denial about it. Well, there's only 100 cases, only 1,000 cases in my country, so I don't need to worry about it, without thinking that the curve looks like this. And scientists are saying that if the curve's increasing, it's soon going to go like this. And so you need to begin to plan for the future needs and think about the future benefits that we're going to need, even if there were short-term costs in terms of having to switch beds over, having to delay certain treatments for patients today. So benefits, risks are important ethically. And lastly is justice. And a major problem has been that we want to make sure that poor people in whatever country we're in the United States, in New York, that they're not disadvantaged. We know that certain groups are going to be at increased likelihood of getting COVID and getting sick and dying. The elderly, the poor, people with prior serious medical conditions. In the United States, unfortunately, people of African-American descent, we know partly because they've had poor access to healthcare to start, they have more prior conditions and they're more likely to get sick. There are people with disabilities. And so we want to make sure that in allocating resources and making these decisions, that we don't increase the gaps between the haves and the have-nots. And these are fundamental ethical issues of making sure that we're not making these gaps worse, that we're not discriminating against people. And I should just say this is going to become increasingly important as we develop treatments and vaccines. There'll be questions if there's a limited supply initially of the number of vaccines and doses of a treatment we have, who should get them? And as I think as we'll be talking later in the session, we need to come up with a fair process of making these kinds of ethical decisions. So ethics are critical. They seem simple, but they're in fact often complex given the uncertainty and the newness of the pandemic.
You're muted.
You're in mute.
Thank you. We're all still learning this new world of virtual seminars. Thank you. So I wanted to turn now to Javier. You've been at the front line of dealing with this disease. And I'm sure I speak for many people when I say that we're grateful for the work you and your colleagues are doing for patients. So if you could tell us about the kinds of trade-offs you've been facing as a clinician and as a healthcare provider during the pandemic in Madrid.
As you know, we faced many trade-offs during the last months, and we have to cope with many of them during the next months. And if you don't mind, while I open the slides, I'm going to move to Spanish to continue the talk.
Está bien.
I think you can see now. I'm opening the PowerPoint. Well, en primer lugar, un segundo. Ahora se debería ver bien. Los dos principales retos o los dos principales dilemas que teníamos al empezar era cómo conseguir dar la mejor atención a todos los pacientes, y cuando hablamos de todos los pacientes hablamos de pacientes COVID y no COVID, y cómo conseguir que todos los profesionales tengan el equipamiento y la protección personal que necesitan, ¿no? Entonces, en este contexto y bajo esas dos premisas comenzamos a trabajar en la epidemia y trabajamos en un marco de trabajo que lo definíamos en 6 puntos, ¿no? O 6 retos o 6 líneas clave para definir la intervención, ¿no? Si veis en pantalla, un hospital está diseñado para una actividad regular. Sabemos más o menos qué actividad tenemos cada año, sabemos cuánta actividad quirúrgica vamos a tener, cuánta actividad clínica, qué número de pruebas de laboratorio, podemos gestionar de una forma ordenada los hospitales, ¿no? Cuando llegó la epidemia, lo que ocurrió es que de repente en el mes de marzo tuvimos un incremento súbito de casos de una enfermedad nueva, de la que no tenemos mucha información y de la que además hay controversia en aspectos clínicos, y teníamos que transformar un hospital por completo para poder afrontar este nuevo reto, ¿no? Y esta sobrecarga de enfermedad, como es el COVID, se tenía que ver de manera obligatoria acompañada de una reducción de la atención al resto de patologías habituales que no son por COVID, ¿no? Entonces, definimos el eje de nuestra intervención, los retos a los que nos enfrentábamos en 6 puntos. El primero era transformar un hospital desde el punto de vista organizativo, arquitectónico, de recursos humanos, preparado para una serie de patologías regulares, tenía que convertirse en un hospital monográfico para coronavirus, donde el 95% de todos los recursos se iban a destinar a una nueva enfermedad, ¿no? Este era el gran reto. El segundo es que además, por las estimaciones que teníamos la primera quincena de marzo, la capacidad del hospital se iba a ver completamente sobrepasada. O sea, que no solo teníamos que transformar el hospital, sino incrementar su capacidad en todos los ámbitos, ¿no? Hospitalización, UBIs, pero se nos olvida siempre la capacidad diagnóstica del laboratorio, la capacidad de los servicios de urgencias. O sea, que no era solo una transformación, sino un incremento de la capacidad. En tercer lugar, la protección adecuada de los profesionales. Y aquí no estamos hablando solo de la capacidad de disponer de material de protección individual, sino también del conocimiento y del manejo y del uso habitual de ellos, ¿no? Y esto era un reto casi tan importante como el disponer de material, la capacitación de los profesionales para su uso. En cuarto lugar, teníamos que ser capaces de mantener el 100% de la actividad, al menos en las áreas clínicamente más importantes, que no eran COVID, ¿no? Estamos hablando de la atención urgente a todas las patologías y de aquellos procesos clínicos en los que el tiempo te impide que se demoren, como son sobre todo la patología oncológica, ¿no? Y la patología grave, como puede ser los pacientes dializados o otro tipo de pacientes similares, ¿no? En quinto lugar, el quinto reto era cómo ser capaces de mantener la actividad con aquellos pacientes crónicos que ya no iban a venir al hospital, puesto que la situación lo impedía, y qué estrategias podíamos poner en marcha para lanzar y poder seguir a estos pacientes a distancia, desde sus hogares o fuera desde el hospital, ¿no? Y en sexto lugar es cómo reactivar la actividad lo antes posible. Ya ha introducido Amanda antes la importancia de no tratar solo COVID, sino de pensar en el resto de patologías. Ahora vamos a afrontar una situación que puede ser, estoy de acuerdo con ella, incluso más compleja que el propio COVID, que es todo el retraso que se está dando en los nuevos diagnósticos, los plazos para los pacientes oncológicos, las caídas en las coberturas de vacunación, el funcionamiento erróneo de la atención primaria, erróneo quiero decir intermitente de la atención primaria, es decir, el sexto y último reto, que es en el que estamos ahora sobre todo trabajando, es cómo reactivar la actividad que no es puramente COVID y cómo intentar recuperar todo aquel tiempo perdido en el resto de patologías que pueden generar un impacto mucho mayor en el sistema sanitario del que ha generado el propio COVID. Estás en Bill, you're in mute. Again.
I think you're muted.
Again. Okay. Great. So it's really quite a challenge to handle the whole sequence of activities that have to go that you have to deal with in the hospital at that level. So I guess the next question is back to Bob. I mean, it seems like the field of ethics was practically built on these kinds of dilemmas. I think the classic one I learned in college was the train going down the track and there's one person here and there's 10 people there. And here you've got a limited number of ventilators or ICU beds. Are there specific criteria or processes that you recommend or that you sort of help people think through to deal with stuff like this? I imagine there are courses for doctors that actually deal with these kinds of things.
Yes, great questions. And we have, as I said, a master's program in bioethics at Columbia, individual courses. And we have people from all over the world who take our courses online. We've had for several years, and people might find that of interest, just FYI. And we've looked at and continue to look at many of these issues. In general, ethically, there are important criteria in terms of the processes one uses and the outcomes. So in terms of processes, it's very important that there be transparency. In other words, and we're talking about how to decide in a country or region or city who's going to get certain treatments, who's not, as well as some of the other decisions and dilemmas that Amanda mentioned, how much we should put resources toward prevention versus treatment, and as Javier was saying, how much we should focus on patients with COVID versus patients with other diseases, where to draw the line. So you want a process that's transparent, that involves stakeholders. You want to hear the perspectives of all the different groups that are involved in some way, different groups of patients, providers, population at large, et cetera. And you, given, as Amanda was saying, to the fact that we're learning more literally every day, certainly every week about COVID as we get more and more data from more countries. So whatever the process is, you may set up, and as Javier showed in his graph, you may set up a process in March, let's say you did in March, well, you may need to reevaluate that in April and in May as we see more about what's happening, how well social distancing is working in a particular area. So you need a ethical process. In terms of the what the content should be, here too there are ethical considerations. So if we have a shortage of ventilators or masks or ICU beds or staff, you don't want to do first come, first serve, because there may be people who get to the hospital first who are not very sick and could be home, or you may get people first who are really sick and are going to die no matter what you do, and having them take up space in a hospital, if there's a limit in the number of spaces you have, when you can give that space instead to someone who will die if they don't get the space, and with the space will survive, you need to make those kinds of trade-offs. So you want to not have first come, first serve. You don't want to do it randomly for the same reason. You don't want to have a lottery where we just flip a coin. You want a process that's logical. And the underlying goal with this process called triage, which is allocating resources when we don't have enough for everyone, you want to give the limited resources to people who would die and if you did not give it to them. So this is going to allow them to survive, and they would not survive if you didn't give it to them. So if there are people who are going to survive anyway, they're not going to get the priority because they don't really need the equipment as much as someone else. And if there are people who are going to die anyway, no matter what you do, they would get lower priority. You then want to have an independent way of deciding. So you don't want me to decide about my patients because I'll say, well, I really like this one patient, I'm going to really help her, or and this person, I don't really know them, so I'm not going to decide. So you want an independent group of doctors, 2 doctors who are not directly involved with the care of a patient to decide. And you want to make sure that they're following clear criteria. You want to assess in terms of how we know if someone is likely to survive or not. You want to use objective criteria, and there have been criteria developed based on whether people have other organ systems that have failed. So if people have had bad heart disease or diabetes, or they have, they're in coma, or they have severe brain disease to start with, they have severe Alzheimer's, where they're, we know statistically that people who have multi-system failure like that are less likely to survive. So you want to decide, looking at, there are scales, looking at, you know, do the person's kidneys work? Do their heart work? Do they have dementia? And you want to be careful you don't discriminate. You want to, as we say, bend over backwards to make sure that you're not excluding groups who don't need to be excluded. So for instance, we're concerned about people with disabilities. So people with Down syndrome, for instance, they may do well with in terms of getting treatment. And the criteria should be not the quality of their life. They may be someone in a wheelchair, let's say, but we don't want to say, well, they're in a wheelchair, so we're not going to help them. It should be based on, will they survive to the discharge of the hospital, or will they be able to go home alive? Right, should be the criteria, so, rather than are they going to be an important person in the world, or are they going to be in a wheelchair that's going to count against them, et cetera. So there are criteria like that we can use.
Okay, so I'm hearing that this kind of putting on in the direction of objectivity and transparency and the logic is a way of removing it from that kind of unfairness that you would feel if it was somebody being privileged or like that.
Yeah.
So Javier, in your, I mean, you've been directly, you deal with this directly. Have you had to face similar decisions, and is there something new you've learned in the past few months because of the pandemic?
Sí, hemos aprendido muchísimo. De hecho, en mi caso, aunque ahora trabajo en la dirección médica de un hospital, es verdad que en el uso de recursos limitados y en ese balance ético de cómo usarlos sí que tengo bastante experiencia, porque he trabajado mucho en diferentes epidemias, tanto en América Latina como en África, como en el sudeste asiático, también en catástrofes naturales, en tifón, tsunamis, terremotos. O sea, que no era la primera vez que me enfrentaba a una situación de este tipo, y creo que el aprendizaje de las situaciones previas me ha ayudado a manejarlo de una forma mucho más objetiva, como comentaba Robert, ¿no? Hay que intentar tener criterios siempre de objetividad, y creo que es muy importante también que esa responsabilidad de la toma de decisiones no recaiga de forma individual sobre el único médico responsable en ese momento de ese caso, ¿no? Tiene que ser una decisión compartida en unidades multidisciplinares y con una serie de criterios que estén basados en la objetividad y, como decía Robert, no en cuál va a ser el futuro individual de esa persona, cuál va a ser su vida o cuál es su calidad actual, sino cuál es la probabilidad real de mejora con ese soporte, con ese recurso, ¿no? Y en ese sentido yo creo que como aprendizaje básicamente nos quedamos en que lo importante es todo el proceso asistencial y no solo el recurso final. Se ha hablado mucho de las UBIs, se ha hablado mucho de los respiradores, pero el curso de la epidemia, si vemos el histórico de los 3 meses, ha tenido una primera fase donde la avalancha de casos estaba en los servicios de urgencias, esa avalancha se desplazó hacia los servicios de hospitalización y posteriormente se desplazó hacia las UCIs, ¿no? En la fase final. Es cierto que la UCI es el recurso más crítico, pero hay que trabajar en las fases previas también para reducir al máximo ese dilema ético y tratar de proveer los recursos necesarios a todos los pacientes, ¿no? Y en ese sentido, yo creo que las preguntas clave no es qué puedo hacer para tener más UCIs o más respiradores, que por supuesto hay que hacerlo, sino qué puedo hacer para evitar que ese paciente llegue a la UCI y que llegue a ese extremo final en el que tengo que tomar una decisión crítica o conflictiva, ¿no? Y en ese sentido, nuestra recomendación o aprendizaje ha sido el de intentar disponer de todas aquellas unidades intermedias que pueden facilitar que no haga falta ese recurso, como pueden ser las unidades de cuidados intermedios respiratorios, que nos han permitido dar un soporte ventilatorio menos complejo que una unidad de cuidados intensivos y ha conseguido que evitemos que algunos pacientes lleguen a ese recurso, y por otro lado nos ha permitido acortar la estancia media de la UBI para que ese recurso pueda ser útil para más personas. Con las unidades de cuidados intermedios hemos sido capaces de dar altas de una forma más precoz, por lo tanto hemos acortado la necesidad de tiempo de UBI de cada paciente y digamos que el recurso de UBI ha podido ser efectivo para un mayor número de personas, ¿no? Entonces, que quizá la clave a nivel de organización en el hospital y el aprendizaje ha sido ese, ¿no? Intentar hacer todo lo posible antes, aprender a manejar mejor clínicamente la enfermedad, incrementar y crear nuevas unidades de cuidados intermedios para que la necesidad de ese recurso sea menor. Y en el caso de que llegue, en nuestro caso hemos tenido que multiplicar por 4 la capacidad de UBI y respiradores. En el caso de que llegue, que esa decisión no recaiga sobre un único individuo, sino que esté consensuada con equipos multidisciplinares y en base a parámetros objetivos, ¿no?
Yeah, I think it's fascinating. I mean, you're pointing out how hard the choices are because we work so hard at loosening the restriction and the constraint, right? I mean, it's not just the number of beds or the number of ventilators, but then you try to figure out how to use them in a way that you can serve more people. The more people you can serve, the fewer hard choices you have to make. It's really fascinating.
Y también el manejo clínico, ¿no? Porque al final la experiencia clínica, hemos manejado mucho mejor la enfermedad en las últimas 2 semanas que en las primeras 2 semanas, ¿no? También hay que centrarse mucho en el aprendizaje clínico, en el manejo de la enfermedad, porque eso está directamente relacionado con la necesidad y con el impacto de los recursos, sí.
Fantastic. So now, those are kind of the trade-offs at the clinical level. I want to step back a bit to the allocating the scarce resources more broadly and return to Amanda on this. You mentioned about health services that are not related to the pandemic, they're being postponed and neglected. And you mentioned some of the figures about how they're, the net impact. And I guess the question here is it possible to reconcile the public policies to slow COVID-19 transmission with a need to maintain the other kinds of health services, and what role would priority setting play in that?
Yeah. So I think there is, and it's all about, you know, Javier laid out those five, I think there were 5 challenges, and one of the challenges was sustain the provision of essential services by getting them out of the hospital and providing them safely to those who need them. And I would say that collectively, no country has really figured out how to do this very well yet. And it's obviously an urgent priority, and it is more of a priority in low and middle income countries where the prevalence of infectious diseases is much higher, right? So vaccination is really important, especially and in the United States where our measles vaccination rate is so low that if we, you know, let our vaccination rate fall any further, which has happened, you know, we're going to be subject to another outbreak that is much more health damaging and to a different group of the population than COVID. I wanted to respond to your previous question because I think there are 2 really interesting examples. And I'll use examples of the UK and the US just because they're quite well documented. So in the UK, what we're seeing is people ventilated that would not be ventilated under normal priority setting protocols. So we'll see a 90-year-old person with systemic, multiple system failure being ventilated, which the NHS would never have done in a pre-COVID world. And that's because the huge, I mean, you might call it hysteria. It seems like the regular structures for deciding who gets what have a bit fallen apart at the clinical level and at the system management level. So that's just a reflection on what we're seeing and the really practical advice that Robert and Javier are giving us at the clinical level. And then another example is remdesivir, which is a medicine that shortens the duration of the illness. In the United States, there was the medicine was held by the federal government, but no one knew what was the criteria for its distribution. Which hospitals got it? Which states got it? Within those hospitals, who was going to get it? And it did end up being first come, first serve. Now, of course, every facility in the United States does its own thing. And that's another great lesson for everyone else, which is try not to do that. You know, of course, there's some facility-specific work that must be done, that committees must operate, but there should be some ability in the way that we decide. We use cost effectiveness criteria, and we use public deliberation around the evidence of who could benefit most in health terms and equity terms to decide who gets vaccinated, for example. In the US, we have a committee that does it. It's called the ACIP. I'm going to forget what it stands for, but it's based at the CDC. The question is, why wouldn't we use those same mechanisms to decide the allocation of these kinds of medical countermeasures? And I think a similar point goes to sort of who are even if we're talking about prevention, you know, we could think of these priority setting committees also thinking about where are the communities that we know are most vulnerable, where we need to take action sooner rather than later. So for water and sanitation, for those decentralized services, in situ services, for example, older persons, homes, hospice care, prisons, slums where there's a lot of overcrowding. We know that information already. I'm very disappointed in ourselves collectively for sort of not being better at sort of, we've been giving a lot of clinical advice from the international agencies, but what we're not giving is sort of a public health approach. Where are the communities where I need to act quickly in urban areas to be able to make these prevention investments that will make a difference in the spread of the disease? So I mean, maybe the last thing to say is, you know, many countries in Latin America do have processes to evaluate new medicines, for example, look at their costs and benefits from a health perspective, from an equity perspective, and make recommendations to policymakers. I'm afraid that they have been slow at recognizing the ethical dimensions of those recommendations, and they have been slow to open those processes up to public scrutiny, to transparency, and to deliberation around the evidence so that it would be a decision that was considered legitimate. And I think that's an area where IDB is working for a long time, and I hope that we can use this opportunity to really elevate and make these bodies that set priorities for public spending much more functional, more dynamic and responsive to what's happening now with COVID-19. Thanks.
Thanks, Amanda. That's really good. Bob, so Amanda's talked about the clinical level examples like the ventilators, and then broader question about the allocations. Is there something you could tell us about that kind of ethical choice, not at the triage level of the patients, but at the public policy level? I mean, the right criteria, cost effective, and so forth. And please try to make it short because we want to make some time for answering the questions we're getting in the chat.
Sure. So briefly, we didn't do this well enough, I would argue, many of us in the United States. So we didn't quite think of the fact that if we put all the resources into treating COVID, what would happen to other patients who needed services? And a lot of hospitals said, we're only going to treat COVID. And there ended up being patients who died at home who, if they'd come to the hospital with heart disease, for instance, we could have treated them. And I think there's a tendency among policymakers to go from denying the illness and underestimating the amount of harm to overestimating. Oh my God, we got to just focus on COVID rather than, as Javier and Amanda said, what other patients' needs are. And obviously we're not going to be able to meet every patient's needs, but there are some people who may die from heart disease if we don't treat them. So I think that these kinds of considerations need to be taken in. And I think that that's why, as part of the process of transparency and multiple stakeholders, you would hopefully hear those kinds of concerns brought on early enough. I think that when we began to see that as a problem in the US, we still didn't readjust our direction fast enough. And lastly, I think just education and messaging to the public is very important here. And I think that's another area where the better we can do that, telling people to social distance, explaining why, even when they don't want to, that can also help in these issues.
Great. Thank you. Javier, so you told us what you did in the hospital in terms of dealing with COVID. How did you and your colleagues deal with these other patients, the other, the ongoing needs of treating other kinds of patients, and what kind of advice would you give to your colleagues in Latin America about this?
Sí, bueno, creo que podemos responder las dos preguntas juntas porque al final nuestras recomendaciones son básicamente también el fruto de la experiencia y yo creo que aquí hay como tres ideas clave. En primer lugar, creo que tenemos que entender que los sistemas sanitarios tienen que estar preparados para convivir con situaciones de este tipo durante mucho tiempo. No podemos centrarnos en responder a epidemias como la de COVID olvidándonos del resto de la asistencia sanitaria. En segundo lugar, si vemos el ciclo de prevención, preparación y respuesta cada vez que hay una emergencia médica, tendemos a empezar por el tercer paso en lugar de por el primero. Empezamos siempre con la respuesta sin estar preparados y sin haber trabajado la prevención, y creo que esto es un aviso muy serio a nivel global de que tenemos que invertir mucho más en preparación. Y cuando hablo de invertir me refiero técnicamente, no necesariamente económicamente, sino estar preparados para afrontar situaciones de este tipo. Y luego me gustaría dejar tres pinceladas que son recomendaciones que sí que daríamos, que son un poco fruto de nuestra experiencia aquí, ¿no? En primer lugar, es muy importante la preparación de espacios y logística. Es muy importante, por ejemplo, y creo que ha sido uno de los éxitos, al menos en nuestro hospital, la respuesta. Hemos conseguido casi duplicar la capacidad del hospital y cuadriplicar la de la UCI sin usar espacios de áreas tan sensibles como son el bloque quirúrgico, donde se hacen todas las cirugías, el hospital de día, donde se hace el tratamiento oncológico, o la unidad de diálisis, ¿no? Donde están los pacientes más sensibles. Eso nos ha permitido, por ejemplo, ser capaces de mantener toda la actividad oncológica del hospital y poder recibir a pacientes oncológicos de otros hospitales del sistema sanitario que no tuvieron esa capacidad, y nos ha permitido, por tanto, mantener toda la actividad crítica no COVID en una situación relativamente normal, ¿no? La segunda idea es diseñar muy bien desde el principio los procesos clínicos del resto de patologías. Esto viene para quedarse, no sabemos realmente cuándo va a ser la segunda oleada, si la va a haber o no, cuánto tiempo va a perdurar. Entonces, mi recomendación es que, independientemente de la situación de cada hospital o de cada país, empiecen a trabajar ya en la convivencia. Es inviable un escenario en el que solo trabajemos en COVID, y hay que definir los circuitos clínicos, a quién se le va a hacer PCR, a quién no, cuál va a ser el flujo de acceso al hospital, cómo vamos a separar y aislar por cohortes a los pacientes, cómo vamos a diferenciar las zonas del hospital donde van a estar, ¿no? Y eso es un trabajo que se puede hacer desde el primer día de la epidemia, ¿no? Y en tercer lugar es abrir la puerta por fin a la medicina a distancia con los recursos o con los sistemas que tenga cada centro. Nosotros aquí teníamos la suerte de trabajar mucho ya con una aplicación propia, el portal del paciente, trabajamos mucho con telemedicina, con eHealth de una forma regular y hemos multiplicado hasta por 10 el seguimiento a distancia de pacientes crónicos durante la epidemia, que nos ha permitido, pues en muchos casos, cerca de un 60-70% mantener más o menos la actividad regular de patología crónica, eso sí, a distancia, ¿no? Entonces, como grandes ideas es trabajar mucho más en preparación, dirigida a entender que la convivencia entre COVID o las futuras epidemias y el resto de patologías va a ser más que necesaria en un mundo tan globalizado como el nuestro. Y en tercer lugar, el despertar o el intentar arrancar todas las iniciativas de medicina a distancia que se puedan, porque se están demostrando eficaces no solo en entornos epidémicos como este, sino para la sostenibilidad de los sistemas sanitarios.
Okay, that's quite a range of very useful ideas. I guess it's another case where we just like, you have to be resourceful and use every strategy and idea that you have. That's great. So thank you for those responses. We're getting a lot of questions from more than 170 participants in the seminar right now. A couple of the questions are around the issue of mental health hospitals and nursing homes, so which are, you know, vulnerable both because resources are going to COVID, but also because they're concentrations of people who are quite vulnerable. And do you have any advice, either from a policy perspective or from the ethical or clinical side, that you would say about how we should be dealing with those?
So I would just say one feeling that we had in many of us in the United States is we didn't pay attention early enough to problems that were going to happen in nursing homes, and we're now seeing these in prisons, I should say, in the United States. So I think making personal protective equipment available there, encouraging, you know, hand washing, things that could be done for prevention. We sort of didn't, as I said, we often ignore that, even though the cases sprouted up in nursing homes. So we need to pay extra careful there in terms of distributing personal protective equipment, make sure they get there. And I should just say, mental health services, I'm concerned that there is a lot of symptoms of depression, of stress, of anxiety out there. And I think these are other issues that we need to address, that countries need to address and consider, and dealing with how to encourage people to exercise, to eat properly, to think of ways to structure their day if they're at home, avoid just relying on alcohol, for instance, as a way to deal with stress, etc.
Sí, yo añadiendo al comentario de Robert sobre todo sobre las nursing homes y residencias en general, yo creo que nos ha pasado a todos igual, ¿no? Hemos llegado todos un poco tarde, creo que la sensación es global. Y ahí yo añadiría a los comentarios que Robert nos hacía es la importancia de que los hospitales, como estructuras habitualmente con más capacidad que muchos sistemas de atención primaria, se impliquen también en el apoyo a las residencias, ¿no? No solo la distribución de materiales, sino también en el asesoramiento clínico. Aquí, como ejemplo, en esa parte de transformación organizativa del hospital, pues sí que montamos diferentes brigadas y equipos de clínicos que tuvimos que formar de una forma acelerada porque no eran especialistas en la materia y estuvieron apoyando a las residencias, desplazándose a diario a muchas de ellas para intentar suplir pues, parte de los déficits de asistencia que muchas de ellas tienen porque no cuentan con personal sanitario o no cuentan con personal sanitario especializado, ¿no?
We also have a question from Wendy Gerber saying one of the silver linings to this pandemic is the necessity for collaboration globally and regionally, and asking about your thoughts about how we can foster collaboration. My sense is that an emergency like this brings out the best and the worst in people. It's like there's a lot of people coming together around it, but there can also be a lot of fighting. Amanda, I don't know if you want to sort of talk a little bit about the international or national collaboration you're seeing around this.
Well, it's a mixed bag, as you say. You know, certainly there's some very interesting international collaboration around the development of the vaccines, therapeutics, and diagnostics led by the World Health Organization, and some commitment to make sure that low-income countries at least have access to an eventual COVID-19 vaccine, although it's still underfunded. So there is, and I guess, you know, the other great thing is the very rapid sharing of the science and the epidemiology studies coming out of China, coming out of the rest of the world. They're being posted without peer review. Data sets are being posted. Code is being posted. That's hugely interesting, although it creates an enormous amount of confusion. I think I saw somebody said 20,000 papers a month are being released on the issue, which makes it difficult to keep up on what do we know, how do we know it, and we're seeing some of that reflected in the confusion on, you know, masks work, don't masks work, just wear the mask. So, you know, it actually is it's great in terms of knowledge, but it is affecting our ability to communicate clearly as public health professionals. If I can, maybe I'll respond to a couple of the questions that I see popping up on the chat. One, and just to illustrate some of the issues that we talked about earlier, one of the participants from Honduras talked about how they're facing both a dengue and a COVID outbreak at the same time. And that sort of begs the question of, okay, we have an expensive, slightly efficacious dengue vaccine, not as efficacious as we would like. But is this the time, you know, if I were an international agency or I were a philanthropist and I wanted to make a difference in health, perhaps now is the time to help Honduras buy the dengue vaccine, right? So that at least they wouldn't have to be coping with 2 massive outbreaks at the same time, or stepping up fumigation against mosquitoes or something like that. And you know, where are the decisions that we're taking in real time about how to manage these competing threats that are consuming so much of our healthcare resources, when we do have things that we could use, but they do cost money. So I think there is some role too for the international community in helping countries look at this strategically and manage some of these other risks. Another point was made about some of the small countries doing really interesting things that have been very effective. And, you know, Vietnam comes to mind, where they did a huge public health push, and then they just did the basic shoe leather epidemiology, as they say, test, trace, isolate. And they've done it so effectively that they still have just a very low caseload. And that's not an island. It's a low middle income country. It certainly is something that we should all be looking at. And I think, you know, not even in the United States, and in the United States, we need to do the same thing. It's just the basics: test, trace, isolate, repeat, 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 repeat. And to finance that, that's an army. Does that exist? What's the status of contact tracing in the countries in Latin America? What do we know about the spend on that? I sense that it's inadequate. I mean, Suriname is an interesting example. They've had 1 case after a 44-day streak of no cases recently. But, you know, what is happening there? Is it just that the outbreak is slow to develop? And then finally, on the issue of like health on the economy, it's and the economy, health and the economy. And I hope that seems clear from all of this. But what I'm a little discouraged by when I look at the multilateral development banks, and I don't want to single out the IDB, I'm mainly looking at the World Bank, is that I see this massive social protection and firm response, and I do not see the surge in health spending at the level that we need to see it to be able to do this massive contact tracing or related. So I'll stop there. I have much more to say, but please email me. Thank you.
Okay. Yeah. Good.
Suriname now has 168 cases. Deanna is telling me in the chat, so I'm completely out of date.
Well, it has been striking that some of the smaller countries have been able to hold it down because they're isolated or have not opened up. And again, we're all kind of wondering what's going to happen as countries start opening international travel and so forth. I'd like to turn a little bit more to that perspective about transparency and objectiveness in these decisions, because it's at every level. It's, you know, what the government's choosing to do. It's what the World Bank and the IDB are choosing to do in terms of allocations, and at the clinical level. There's a question from Luis Fernando Gomez about involving citizenship and what it is about participation. I mean, I thought it was striking what Javier and Bob said about you don't ask a single doctor to make these choices, you have a committee doing it. And in a sense, it's kind of the same issue for public policy. If you have it's different to have a president making the decision on their own or a minister of health than to having some kind of a public participatory process. Are there specific ways you've seen that done in different places that would be good models for people to think about or other issues that come up when you think about participation?
So I think making sure you have key stakeholders. So you don't want to, having it as open as possible. You don't want a free-for-all where it goes on for months and months and everyone who gets, says something. But I think to have a period of make it clear and then have a period of public comment and then have the comments evaluated carefully. I think those are important things. I think it's the commitment to transparency and to stakeholders. In other words, to hear from, I think unfortunately in the US, for instance, in a number of states, they developed criteria and did not include disability advocates or include people from the African-American community as much as they should have. And so those communities then which are overly burdened by the epidemic or might be, I think, had not been included, and so processes had to quickly catch up. So I think thinking through who do we need to have at the table, not just who happens to show up and it's the usual suspects, but I think since COVID affects all of us in all walks of life, it's important to have different perspectives. Who are the essential workers? Are they the poor people? Who can represent them? Things like that. So I think it takes a conscious effort.
Sí, aquí a mí me gustaría añadir en esta perspectiva de limitación de recursos, que creo, esto es un punto de vista personal completamente, que los países de renta más avanzadas quizás hemos cometido un error estratégico durante los últimos años y es dar a entender que nuestros recursos son ilimitados y que este tipo de decisiones no las tomamos en la vida real, porque antes de la epidemia se tomaban decisiones como estas. En las UCIs se toman decisiones habitualmente como estas casi con cada paciente, casi cada día, porque con cada paciente, bueno, al final los recursos no son ilimitados y siempre hay que tomar decisiones individuales, ¿no? Entonces, quizá aquí nos hemos equivocado dando a entender que nuestros sistemas son ilimitados, que los recursos no se terminan y que este ejercicio de toma de decisiones sobre los recursos es algo excepcional en el COVID cuando no lo es, ¿no? Eso, obviamente, en el impacto en la opinión pública ha sido más negativo porque es más difícil de comprender. Si lo hubiéramos hecho mejor antes, si se entendiera que esto es una situación normal, creo que no habría sido tan complejo esa parte de opinión pública, ¿no? y de percepción colectiva de la limitación de los recursos.
We're sort of running out of time here. I want to take one last question from, we have a question from Vicente Irene Tafua Osvaldo about policies to help health professionals deal with these issues. I mean, you mentioned the normal stress of being under all this stuff. What kind of public policy and managerial approaches do we need to do to help people manage these decisions ethically and trade-offs in their work as health professionals?
So two things come to mind. One are legal protections for healthcare workers. So I don't know the state of liability and malpractice in all the countries who are represented here today, but at least the United States, doctors were told, you're going to have to do things differently and not follow usual standards of care. But if you don't follow usual standards of care, you can get sued. And I think that puts extra strain on doctors. I think there's a need, too, to recognize the enormous mental health strains on doctors. And so hospitals need to be aware of that. At my own institution, we had a COVID doctor who killed herself. It was just too stressful, et cetera. And so I think institutions need to pay attention to avoid burnout, to realize that we're often taking doctors from other fields and having them work in ICUs, try to get as much training for them, as much support as possible.
Javier, you're muted if you're, yeah.
Para completar el comentario de Robert, estoy completamente de acuerdo con él y por dar algunos ejemplos quizá que puedan ser de utilidad para algunos compañeros y sí que en este sentido nos sirvió el aprendizaje de otras epidemias. Desde el principio, por ejemplo, hemos tenido unidades de apoyo de salud mental a todos los profesionales y, como decía Robert, no solo en las áreas críticas, sino a demanda de todos los profesionales que lo necesitaran y de forma estructurada para aquellas áreas que sí que estaban luchando contra la enfermedad de una forma más intensa, sobre todo porque hay que tener en cuenta que este es un contexto donde el miedo es muy racional y a pesar de ser profesionales sanitarios perdemos un punto de vista objetivo cuando esto nos toca de cerca. Solo en España ha habido, por lo menos documentado, más de 70 profesionales sanitarios fallecidos. Creo que los datos en Italia también son similares y además estamos hablando de una enfermedad realmente de la que todavía no conocemos mucho, ¿no? Todos somos padres, tenemos hijos, familiares enfermos. El miedo colectivo que se ha generado ha sido enorme y el apoyo en salud mental tiene que ser uno de los ejes tan importantes cuando hablamos de protección del personal. No solo hablamos de máscaras o de batas o de guantes, sino hablamos de protección en salud mental. Y hay que poner exactamente la misma intensidad en esa estrategia desde el día 1 que en el tener en el almacén guantes o máscaras suficientes.
Amanda, do you want to pitch in on that? I guess it's also related to having a much, you're talking about the surge in spending. It's like, where's the money for masks, for protective gear, for mental health support, things like that. I don't know if there's other personnel issues that come up.
Exactly. I mean, you just imagine in an ideal world, I mean, especially because now this initial period is over, but we do know that the outbreak will last another year or more. And therefore, this is an ongoing problem, that situation of fear and challenge, and it should be really part of our planning for the sector. We need to bump up our epidemiology enormously, and we need to bump up the protection of the health workers in all respects, not just physically, but mentally as well.
Okay, well, thank you very much, all three of you. I am sorry that the time goes quickly. It's been a great session. I think we've heard a lot of valuable ideas that were discussed during the webinar. I'm sure that all the information you shared with us is going to be very relevant to the people who are listening in. So I want to thank everyone who joined. Sorry we couldn't answer all the questions, but it's great to have the interest. We'll keep you posted on the next webinars of our Policy Dialogue series on strategies to respond to the COVID-19 pandemic. And well, thank you, and look forward to meeting you all in person someday.
Thank you.
Thank you all.
Thank you.
Thanks very much.
Bye-bye.